Good evening, respected leaders of modern medicine and dear friends. It's with immense pleasure we are sitting in this avenue on every Thursday evening. Modern medicine is changing day by day, and people at large is depend on health for no doubt. But two things are very important. Prevention of comorbidities. There are a lot of emerging illness coming in. And whenever you saw COVID, right? When someone is afflicted with the COVID, if that person has some comorbidities, the prognosis becomes very tight. So let us not carry any comorbidities along with us, so that we'll be able to manage any challenges if at all it comes. And here comes the cornerstone of modern medicine, the general practitioner. And there are a lot of general practitioners, and there are a lot of doctors even managing themselves. That's also very important. So here comes the importance of IMA College of General Practitioners, and the IMA College of General Practitioners Kerala is so happy with the theme of the IMA Kerala State this year, empowering healer and enhancing healthcare. Friends, with gratitude to the state leadership, IMA, Dr. M.N. Menon, State President IMA, Dr. Roy R. Chandran, State Secretary IMA, and all the leaders of Indian Medical Association who gives the energy and enthusiasm for we people. Okay, we are just, in front of you as an icon. We are with the great blessings of this mighty organization. Friends, as you all know, the College of General Practitioners do carry a WhatsApp channel, which is a hit nationwide. Please do visit us. We'll be sharing more and more clinical updates and details there. And also, please do not hesitate to share your views, maybe a topic, maybe a faculty that you would like to listen to, maybe a doubt, a clinical or non-clinical doubt, which you would like to clarify. Send them at IMA CGP KERALA@gmail.com. Friends, this webinar started on 4th June 2026. I am sure it's into your hearts, it's into your hands, and it's into your mind. The essentials of every day in modern medicine, the weekly webinar with the same Zoom ID, same passcode, and same link. Thanks for your acceptance. Friends, today we have a very special session. Probably whenever we discuss about practice, we discuss about hypertension. And even the thinking about the practice might lead to hypertension in some. If it is not a joke, maybe sometimes it is a reality for someone. We have a great personality, a silent leader, always humble. Always, I have never seen him, agitated anywhere, always smiling. And head of Department of Cardiology, PRS Hospital, Thiruvananthapuram, is none other than, whenever he teaches something like, our favorite teacher, Dr. Tiny Nair. On essentials of every day in modern medicine, he is here to present hypertension essential facts before us. So I invite Dr. Biju Nelson, our vibrant secretary, a great leader par excellence, to formally introduce Dr. Tiny Nair for say. Over to you, Doctor.
Good evening, Director of Studies, Dr. C.V. Prashant, our Chief Guest of the Day, Dr. Tiny Nair, Senior IMA leaders, friends. It is my great privilege to introduce today's distinguished speaker, Dr. Tiny Nair, one of India's most respected cardiologists. He is the Chief Cardiologist of Department of Cardiology, PRS Hospital, Thiruvananthapuram. With over 3 decades of experience in clinical cardiology, interventional cardiology, and medical education, Dr. Tiny Nair is a fellow of American College of Cardiology, European Society of Cardiology, and an FRCP from Edinburgh. He is an acclaimed teacher, prolific researcher, author in several popular medical journals, and also inspired thousands of physicians across India. His main contributions to heart failure, research and hypertension, then preventive cardiology and continuing medical education. On behalf of IMA CGP, it is my proud privilege to welcome Dr. Tiny Nair. We are honored by your presence and eagerly looking forward for your insightful lecture. Now, ladies and gentlemen, please join me in welcoming Dr. Tiny Nair for this academic session.
Thanks
Thank
a
you.
lot, Dr. Biju Nelson, for your introduction. Friends, we are just ahead of starting the program. But I am surprised by the presence of a great personality. One of the senior most doctor among us. Probably he is the senior most. Let us hear a few words from him. Sir, let me just check. He's here. Dr. T.P.V. Surendran from IMA Calcutta. Surendran sir, are you there? Sir, can you hear me? A man from 1960.
I can hear you. I can hear you.
Sir. Please share a few words of introduction.
I am an old man. I am an old man, and finished in 1996. I have finished this thing, our medical college career.
1996, not 96, sir. His registration is 3000.
1960, I have joined in the medical college. 1996, it is completed. Then, of course, I have joined in Calicut Medical College as a tutor in pharmacology. Then, of course, I was serving Kerala Health Services for more than 16 years. 16 years I was working for government service, but unfortunately, because of political issues, I was because it was not resignation, I was thrown out of the service. I was thrown out. And of course, I have started a small hospital in Calcutta, that is a Leo Hospital. That's all regarding my this thing. And
Sir, how many years of
Dr.
your practice,
Prashant
sir?
is, of course, he is taking a lot of interest. He is actually he was one of the moderators of IMA CGP in South India, which was held in Calicut. It was very good, and he's having, and I have read in, of course, he was having that this thing, Nammude Arogyam. He has signed like anything. It was very, even now, of course, Murali also is good, but Prashant, of course, he has got his own charm, his own way of writing and all these things. Anyway, I wish the best for this is IMA CGP's this thing. We have to encourage. We have to participants should be. It is less. I think it is only 80, 82 for the time being. So definitely we have to participate more in our numbers.
Thank you, sir.
I wish you all the best.
Thank you.
Thank you.
See, dear friends, why I invited Surendran sir particularly is to share two messages. He is a man of 60 years of clinical practice. And second thing is, he is still attending training programs, which indicate most of us think that we know everything. And friends, please share this story with everyone. You're all so positive, and there are a lot of people sitting outside and thinking that they know everything. So please, dear friends, please share this story. Sir, over to you, sir.
Thank you very much. Okay.
Thank you, Dr. Prashant. Thank you, Dr. Biju. Thank you, sir, for that nice words. I'll share my screen. Give me a moment. Can you?
Yes, sir. White screen can be seen.
No.
It's okay. Now the colorful.
Okay, right. So, good evening. We will talk about hypertension. Now, whenever we do any kind of meeting or talk, that picture that you see is the world's most premium meeting. and that meeting is the World Economic Forum at Davos. You can see that 2026 date. Right? It's world's most important and premium meeting of world leaders. 140 world leaders from 500 odd countries attend that meeting. Major decisions are transacted, right? Major decisions like what is going to be the environmental issues, what is going to be the health budget, what is going to be the about artificial intelligence, what about global warming, everything is discussed. But think of it. Think of it. Major meeting, major decisions. But when you ask someone on the road, hey, what he will say? He will say, sir, will this meeting, will it make my milk cheaper? Will it make my bread cheaper? But I don't bother about big things like pollution and global warming and all that. I'm bothered about, will it do any good to me, right? Same thing is when we talk about a medical meeting, right? We have so much of every weekend, every day. Now we sit in front of Zoom meeting. But the point is, the first question that we need to ask for any meeting to take home is, will it make a change in my patient care tomorrow morning? Right? I am hearing all that for the next about 40-45 minutes. Will it make any change in the next patient I see tomorrow? So every meeting has to have that answer. Otherwise, all this big stuff and beautiful slides all become a waste. And we will try to do that. We will look into each small topic, look into the background pathophysiology, which might look a little complex for the young physician. But after that, we will keep the message simple and short so that it can be used for practical purpose tomorrow morning. Right? We know that, a blood pressure instrument has changed. You see the mercury manometer there. Then came the aneroid blood pressure apparatus, and then, of course, the automated instrument. Now, they are essentially very, very different. We'll go into that later, right? But today we know that mercury has been called an environmental toxin, and mercury manometers have been taken away. The stuff that all of us relied on for decades and decades during our medical school and training, we worked with those. Now they're gone because you can't use anything which is filled with mercury anywhere in the world, right? So mercury manometer is out. So you have aneroid and you have automated. Now, between aneroid and automated, understand these two that you see there, they're totally different. Now, try to understand so that we can come to the logical conclusion of what we know. This is something that everyone asks, right? So when we inflate the bulb, we put the cuff, we are measuring the blood pressure, we are inflating the cuff, so the pressure goes up, you see that curve going up, and then we deflate, the pressure coming down, right? So we inflate and we deflate. And as we are deflating, we look at appearance of the Korotkov sound and maybe muffling or disappearance, which is phase 1 and phase 5. And we say, okay, BP is 140/90. This is what we do, and that is standard, right? Now understand that this is the Korotkov sound the moment the artery opens, and then when the artery goes back to its original shape. But when we are talking about pulse amplitude, that is totally different thing. This was just we are inflating and deflating and looking at the artery opening and the sound appearing. But an automated instrument does not capture the sound. All it does is look at the amplitude of the pulse. Now look at that. When we do that, you see something like a diamond, right? So slowly, the amplitude of the pulse, it is not the sound, increase and then gradually decrease. So if we catch the maximum amplitude in the center, the software does that, you get the maximum amplitude of the pulse and then go back minus 50 or plus 70. That's an algorithm which is built into that system. That's a standard algorithm. And that is how systole and diastole are picked up. So they're totally different method. But today, every data, every large study, every trial is with an automated instrument. So we have to learn about automated instrument and what are its fallacies with it. Now understand that when we are talking about the sound that you and me, we hear during BP check, right? Phase 1 and that is phase 4. They are different from the systole and diastolic measurement of the automated blood pressure. They're different. And what way are they different? That is the sum and summary. Forget about all this stuff and amplitude and all that. So what happens is it gives you the automated BP instrument, gives you a little higher systolic blood pressure. But doesn't matter. All the guidelines and everything is built upon automated blood pressure measurement today. So it gives slightly higher systolic blood pressure. So if you had checked your patient's blood pressure by a manual method, it was say 120 by 80. The automated will show maybe 125 by 60 or 70. Now that is not very important. The difference is very minor. But what interesting comes is here. It shows a lower diastolic pressure. So all of us who have got the problem that in the middle of the night at 10 o'clock, one patient will call up and say, "Sir, innale kande enakku BP medicine editharnallu, tell me Satan." Adu kaichide BP bhayankara low ayipoyi. Athra low ayipoyi. Ayyo sir adu 40 ayipoyi. Ayyo 40 BP 40. Endu paranga sir 120 by 40. Ende BP participant kanikkunnundu. That is because of the inherent calculation of your automated BP. So tell your patient that please don't look at the diastolic pressure because the automated instrument may come down to as low as 40, 20, 70. Doesn't matter. It will not hurt you. Look at the systolic blood pressure. So automated blood pressure instruments give a higher systolic, lower diastolic. And of course, because it is looking at pulse amplitude, is invalid in atrial fibrillation. Atrial fibrillation is an arrhythmia. Pulse becomes irregular. There it is not valid. We now have very expensive newer models which have an algorithm which can detect the AF and still give a good reading. But generally, most standard blood pressure apparatus are invalid in the background of AF. Yes. So what did we learn? Learning number one is that if you are using Android, it is fine. If you're using an automated instrument, it shows a little higher systolic pressure, a little lower diastolic pressure, and it is invalid in the presence of arrhythmias. So that is point number one. So automated instruments, higher systolic, little lower diastolic, invalid in presence of atrial fibrillation. Right. Second thing is measure carefully because that is where the whole thing lies. Right. So the American Heart Association, we are all members of the Hypertension Council of the ACCHA, has put this cartoon, beautiful cartoon. Can you find the common mistakes in the picture? It is like we give our children, right? Can you find the difference between two pictures? Now, if you see in this picture, the doctor is recording blood pressure. Everything is abnormal. You can see that there is a cup of coffee. So coffee should not be taken. You can see the blood pressure cuff is wrapped over shirt. That should not be done. You can see his legs are dangling. That should not be done. He has no back support chair. That should not be done. So these are all showing that what you should not do, right? So we all know that left arm bare, kept on the table, firmly foot on the ground, straight back chair, should not have a coffee within about 30 minutes of the recording and all that, should not talk. Okay, fine. But many of us do not realize as to how much difference each one of them make. Hey, we just put in measure. How much difference? 1 to 5 millimeter, right? You are wrong. Look at this picture. Look at this picture. This is again by the American Heart Association. They have studied all over the world and the data are all proven by available data, published data. Look at that. If you talk during blood measurement of BP, it can go up to 4 to 19 millimeters. Just patient is talking to you when you are measuring BP. If he has taken the first cigarette of the day, 20 millimeters. His arm freely hanging may increase the BP by 5 to 20 millimeters. Lack of leg or back support, 5 millimeters. Full bladder, he has not gone to the toilet, washroom, 4 to 33 millimeters. Over the shirt measurement, 3 to 5 millimeters. A cuff which is too big or too small because your hospital clinic doesn't have a proper size cuff, 5 to 20. Drinking coffee, 3 to 15. Legs crossed or straight, 3 to 15. There's a difference that can come in minor things. See, think of that monster word, 15, 20 millimeter difference. That makes a difference between hypertension and normal BP, right? So you might diagnose that he has got significant hypertension. Actually, his bladder might be full. Or maybe he had taken a cup of coffee. Or the BP is looking little down. It might be that you are recorded over shirt. So it is important that we keep these things in mind. Patient sitting straight with a back support, arm on the table, blood pressure cuff proper sized, put over the arm, bare arm, not shirt. Legs are not dangling like that, firmly put on the ground. He is not talking. He has not smoked a cigarette or taken a cup of coffee just before examination, and he is comfortable. So take care the way you measure your blood pressure. Right. From there, what about symptoms? Lot of people, patients still believe that blood pressure produces headache. So they will say, doctor, you should need to check out my wife because she now complains of headache. I think she has hypertension, BP, right? Or they would say, oh, my wife is now getting so angry, BP on the cardio. But we know as physicians that 99% of hypertensives have no cardiovascular symptoms, right? So most patients have no cardiovascular symptoms. So blood pressure is an asymptomatic disease. It can be detected only by measuring properly. So it has hardly any symptoms, right? And that brings us to what should be the blood pressure goal. See, last about 10 years, when it's fighting with this, should it be 140/90? What should be the ideal goal of BP, right? Should it be 130/80? Should it be 140/95? And now universally, keep it in mind that BP goal is less than 130 systolic and 80 diastolic. Let us not create a confusion in our mind. There may be difference in guidelines, CSC, European guideline, American guideline, Indian guideline, Japanese guideline, but generally 130/80, right? Is it dependent on age? No. Basically 130/90. And if you are interested in little history of how this came in, there's a large trial called Sprint trial, 10,000 patients. They found that if you keep it below 130/80 versus below 140/90, 130/80 is significantly better, right? Then they looked into a trial called, the Sprint trial was a very good trial, but they excluded diabetic, excluded stroke and all that. So they took people with diabetes and found that in BP road trial, diabetic, same thing. Less than 130/80 was best. They looked at people who had a stroke, who were Asian, people like us, right? Not American. People who were diabetic, same, 130/80. Then they took very elderly people. The trial is called a STEP trial from China. Elderly people, they looked at older people and again 130/80. So the goal today, let us not go into debate, is 130/80. Why? Because of three things. 130/80 or below, reduce MACE. What is MACE? Major adverse cardiac event. So in all cardiovascular trial, you will see this word used, MACE, MACE, MACE. What is MACE? Major adverse cardiac event, meaning that stroke, heart attack, and cardiac death. So these three things in vascular disease can kill a person, right? So stroke, myocardial infarction, and cardiovascular death are MACE. They are reduced. Second, 130/80 and below significantly reduces mortality. And, we used to learn of a term called J curve. J means if you reduce your BP too much, the mortality would increase. Less than 130/80 doesn't have a J curve in any of these large studies. Because today, we know that BP goal clear is 130/80. Doesn't mean that anybody who is 140/90, you need to give 5 medicines. No. But your goal is 130/80. He can do a better lifestyle, stop smoking, stop alcohol, less salt. Reaching goal, fine, right? But the point is 130/80. Now, why are we wasting time about blood pressure? Because uncontrolled blood pressure can give rise to stroke. Uncontrolled blood pressure can cause loss of vision, hypertensive retinopathy. Severe hypertension can cause myocardial infarction, atherosclerotic vascular disease. Severe hypertension can cause cardiac failure. Severe hypertension can cause chronic kidney disease, CKD. It can start with a little albuminuria and progress to kidney failure. It can give rise to sexual dysfunction. These are all well known. So complications of these are called target organ damage. And then every year, the Americans always feel happy if you change the terms. This is called hypertension-mediated organ damage, HMOD, whatever, target organ damage. So stroke, heart attack, heart failure, visual loss, kidney disease, sexual dysfunction. These are complications of hypertension if it is untreated. And hypertension comes far, far earlier than all these damages take place. So if we control them, the damages will not happen. Right. Now, this is a concept that many people fail to understand. And this exactly reflects what Dr. Prashant said at the beginning. Okay, let us say we have a patient who has hypertension. Hypertension patient, 40-year-old, is a red shirt. We call him Mr. Simple Hypertensive. In fact, this model was developed by us, and then now it has become pretty popular all over India and perhaps all over the globe. Simple hypertensive concept is that this man is simple because he has no other risk factors. So he's not a diabetic. His cholesterol is normal. He does not smoke. And as you can see, he's not obese. Second, he has no target organ damage, HMOD, hypertension mediated organ damage. He never had a stroke, heart attack, heart failure, sexual dysfunction, or retinopathy. And also, he has no comorbidities. This is what Dr. Prashant was talking about. Comorbidities are what? Frail, chronic lung disease, chronic liver disease. A person who is not just elderly, but can't walk, frail, right? They are comorbidities. Now, the point is, if the patient has any of this, a risk factor as over and above hypertension, a target organ damage, or a comorbidity, we call it complex hypertension. Now, you might say, what great fun. Simple? He has any problem, he is complex. No. The point is, if he has a simple hypertension, you can use any medication that comes to your mind. You can use a beta blocker. You can use an ACE inhibitor. You can use an angiotensin receptor blocker. You can use a calcium antagonist. Right? You say, I will use cilnidipine, calcium antagonist. Fine. Somebody say, no, I would prefer a telmisartan. Do it. Somebody say, no, I know bisoprolol is good. Use. Somebody say, no, I have heard that diuretics are good. I will use chlorthalidone. Fine. In a simple hypertension, the main thing is you need to reach goal blood pressure, less than 130/80. Whatever you use, basically same thing. But the moment you have somebody with a complex hypertension, the picture changes. There are specific alteration of pathobiology. If you had an MI, you need a beta blocker. If a cardiac failure, you need an ACE inhibitor, for example. Diabetic, you need an ACE or an ARB. Okay, somebody who has a bronchospasm asthma, you will avoid a beta blocker. Get the point? So if you have a complex hypertension, you are choosing your drug carefully rather than giving any drug. And that is why this is so very important. They might also need multiple drugs. And in our practice, think of it. How many are simple hypertension? Very few. Many simple hypertension who walks into your clinic might have what is called a white coat hypertension, right? They have a white coat hypertension that may not even need treatment, but most are complex hypertension. And they have poor response to one single agent. That is not our question. So the moment you get a patient tomorrow of hypertension, ask yourself 3 questions. Risk factor or diabetic, dyslipidemia, smoking, any other risk factor other than hypertension. Second, stroke vandittundo illa. ECG left ventricular hypertrophy undo illa. MI vandittundo illa. Oru prashnam illa. Third, comorbidities undo. Chronic lung disease, liver disease, multiple problems, frail illa. So it's a simple hypertensive. Treat. Yes, you give him telmisartan. Okay, or give cilnidipine, whatever. Blood pressure comes down, he will be fine. Or even if you wait, the chance of complications are less. But in a complex, you need to be careful. Many people start thinking that the moment you are thinking about a hypertension, your treatment is medicines, which is wrong. You should limit alcohol intake, smoking cessation, high intake of fruits and vegetables, restrict salt, physical activity, increase calcium, potassium, and magnesium in diet, reduce body weight. These are extremely important. Though none of us highlight it in any meeting, right? We straight away go for medication because the pharma company insists that medications are very important. And we technically think that they are they're important. But you should always try. And in many patients, you see nothing. Patient might be having obesity and obstructive sleep apnea. A simple CPAP might cure his hypertension, right? He might be taking too much of salt. Ask him to reduce salt. His blood pressure might come down. He might be terribly obese. Ask him to do regular exercise and reduce body weight. So alcohol, very common in Kerala. They might be taking every night a drink, and next morning when they come to clinic, your blood pressure will be high. So first is all this lifestyle modification. But of course, Second thing is medicine. And here we should learn something. See, if you look into all the large trials and look at the average number of antihypertensive drugs, look at that. Look at that. Most will need more than 2 medications. These are all trials, world trials, all big trials, where they have brought down blood pressure to nearly 140, 90 and below. That itself took at least 2+ drugs. Hardly any patient who got control less than 2. Right. So everybody would need 2 or more drugs. So that is why we today say, if you have significant hypertension, start your patient on 2 combination drugs rather than 1 drug. Right. That is why we say start at least, most would need 2+ pills. Okay. So compliance. If you give him so many medicine, will he going to eat? No. That is why we say put it in 1 pill. So the concept now is 1 pill which contains probably 2 chemicals and 1 goal of blood pressure. So it makes simple for everybody to understand. Rather than complex, I have to look into my phone or I have to look into literature what medicine I give. No. Simple and attainable goal. Now this looks a little complex, but let us try to make it simple for us to start understand the next stage. Very simple, very simple. This is what drives hypertension. What is it? 1, of course, sympathetic nervous system. Everybody knows that, right? If I'm sympathetically charged, my heart rate is high, I'm excited. Second, renin-angiotensin axis. This is a hormonal drive secreted by kidneys that maintain hypertension. Third is blood volume. And fourth is peripheral resistance. So don't get confused. There's nothing big about it. So one is hormones, one is the blood volume, one is the peripheral resistance, and one is the sympathetic nervous system. These are what drives hypertension. And that is why to control blood pressure, we have blood volume reducing agents like diuretic and SGLT inhibitors. We have peripheral resistance lowering agents like calcium antagonists, calcium channel blockers, cilnidipine, nifedipine, amlodipine, right? We have the RAS inhibitors like ACE, ARBs, ARNI. We have sympathetic blockers like beta blockers. So this is all about treatment of hypertension. And we combine them because inhibiting multiple pathways are more effective. So if you curtail 2 of this pathway, your chance of success is more. That's why we are saying use 2 drugs together to start with so that your success is more, right? Not just that. Suppose you are using a diuretic. Reflexly, the RAS gets activated, right? So when you use a RAS inhibitor with a diuretic, you get better effect. You use a calcium channel blocker like nifedipine or amlodipine or cilnidipine. Peripheral resistance drops, but the heart rate reflexly increase. Use a beta blocker along with, so it gets controlled. So diuretic plus RAS inhibitor, beta blocker plus calcium blocker. These are good combinations so that not just the patient blood pressure is controlled, but it is a sustained long-term control. And that is why we say inhibiting multiple pathways are more durable, not just more effective, more durable because the counter-regulatory system doesn't have its effect. Okay, so forget about all those problems and look at something very simple. This is something that we tend not to look into. And I urge everyone, every general practitioner, that this needs to be focused. This is something that we don't do, and that is heart rate. Why we are talking about heart rate? This is it. Your blood pressure apparatus gives you the systolic, diastolic, and also the heart rate. But do we really look into heart rate? Okay, 70, 80, 85, 86. Today we know that the heart rate is as important, or if not more important, than blood pressure control. So I repeat, heart rate is as important or more important than BP control. You know, this was a very interesting study that came long back, 20 years back, 2004. Okay, why we are showing this study, you would understand a little bit later. Don't need to understand studies. We don't want to bore you with studies, but this is a 15,000 patient data for 5 years. What they did was, these are hypertension patients. They divided them into 1, 2, 3, 4, 5 categories. One group with a heart rate of less than 50. Another 50 to 60. Then 60 to 70. 70 to 80 and more than 80. So according to heart rate, they divided them into 5 categories. They are all hypertensive patients, right? And then when they looked into the data of 3 years, 5 years, 1,500 days, look at that. One group had a low heart rate and low BP. Very good, excellent group. They had the best outcome. The graph is lowest, right? Their event rate, primary event rate, that is death, MI, stroke, was least. But look at that one top group. Blood pressure control, we are happy, 120/80. But heart rate was high. They had a bad outcome. And that is why we are saying that it is important that you look at the heart rate in your BP apparatus. And we need to control the heart rate. So if the heart rate is more than 80, the endpoints are terribly different. PEP is primary endpoint. That means stroke, myocardial infarction, death. 1.6 times higher. Heart failure, 2.2 times higher. Myocardial infarction, stroke, sudden cardiac death. Everything is high if the heart rate is more than 80. So please look at the meter and look at what has happened to the heart rate. See, this is a very large data of 3.3 million patients. Look at that, all-cause death. All-cause death. This is heart rate. When the heart rate crossed 75, the mortality went above that straight line, right? Similarly, when they looked into the night heart rate, sleeping heart rate, again, more than 70, the mortality went high. So the point is, it is important that we look into that heart rate and don't forget not to miss it out. Why it becomes so important in India? This is a trial that we about a dozen of us joined together and did this study. It's called the India Heart Study. Right. In India Heart Study, there were about 18,000 patients. And you know what we found? We found that the resting heart rate of Indian patient on an average is 83 beats per minute. 83 beats per minute, not 70, not 65, which is different from the Western population. And this was the first data that shown that in India, our average heart rate is faster. And perhaps we should give drugs that reduce heart rate like beta blockers, a higher hierarchy and prescribe earlier. So Indian hypertensives have a fast resting heart rate. The first data that came, and people respect this data so much, a huge database we collected, the heart rate of Indian patient is faster. So we have a faster heart. So we probably need to choose differently. There's a very beautiful article that came in the journal Circulation editorial by a gentleman called Takuya Kishi. He's from Japan, and he's an expert in hypertension. See how he puts hypertension. He puts hypertension as 2 groups. One, less than 80 on the left. So he says, have lower cardiac risk. And more than 80 heart rate, higher cardiovascular risk, and needs beta blockers. So simple. In your meter of blood pressure, this is take home. Look at that heart rate, not just the BP. BP control, fine, you are happy. But look at the heart rate. If heart rate is not controlled, probably this patient needs a beta blocker. Because heart rate needs to be cared for. A higher heart rate indicates higher mortality and morbidity. Very, very important. Right. So don't forget heart rate in your BP apparatus. Indian hypertension with heart rate, which is fast. Fast resting heart rate is bad. Consider beta blockers. Okay. There are some special Indian subsets which many people don't know, but we had reported it for the first time, right? This was years back. I think this was in 2004 when we reported this unusual subsets in India. And one of them was very interesting, and one of them was this isolated systolic hypertension. You know, everybody knows that elderly people have systolic hypertension. So normal BP is 120/80. An elderly person who is 80 years old will have a BP of 170/70. So systole is high, diastolic is normal. It's called isolated systolic hypertension. We know that elderly people have isolated systolic hypertension. That was believed, that is in all guidelines. But for the first time, we showed that in India, we have something called the isolated systolic hypertension of the young. And we named it ISHY. Today, it is an accepted subset, ISHY, where Beta blockers does so much of good. These are young boys who work in IT sector, IT hubs. They work at night. They are under tremendous pressure. They are under tremendous stress. They have tachycardia, all sympathetic overdrive. They work at night, the American time, right? And they eat all junk food in their campus. So isolated systolic hypertension, exactly like what you see in elderly. But this is in the younger population. In fact, this is one of the articles that we had written. This was an, I think, yeah, this was an editorial where we wrote about isolated systolic hypertension of the young, shifting focus from father to son. So, we were looking at the father hypertension. Now we are focusing on the son. So isolated systolic hypertension of the young. This is a subset that we reported from India. And now everyone knows that that is a subset. That is a specific subset. We need to treat them correctly. Right. This everyone knows. What is it? Different, something different, right? Everybody is scared of a hospital. The moment you take BP in your hospital, this is a Western, you can see the American doctor and a patient, blood pressure goes up. Nice, timid, scared, but the BP goes up. Everyone knows that, right? Not just that, this is called white coat hypertension. So the moment they see our white coat, the blood pressure goes up. We know that it could be people who are very anxious. They get, white coat hypertension. You see somebody, you say that your BP is high, you say, no, sir, what happened was just before I came, I had a fight with my wife, right? Oh, minor thing, right? Or you would have said, sir, I was waiting outside your clinic and I had some strong coffee. Or maybe that, sir, lately I am using too much of salt. So this all can cause rise of blood pressure. But in India, we are talking about a different kind of blood pressure. White coat blood pressure, that's different. People are waiting outside our OPDs for hours, right? These are outside our OPDs. People are waiting to see us. So obviously people will go up, right? So our white coat hypertension is different from the Westerners. They're not just panic, they're angry, they're troubled, they're waiting for a long time. So the blood pressure tends to go up. And that is where today we are talking about that blood pressure has walked out of the hospital. So hospital is not a good place to record blood pressure because he's anxious, he's angry, he's taken coffee, his blood pressure might go up. So we should check blood pressure outside the hospital. How? And that is where today the focus is on ABPM or ambulatory BP monitoring. All the good hospitals, all the modern hospitals offer multiple ambulatory BP apparatus so that you can just fix up and go. The BP cuff inflates once every 30 minutes daytime and once an hour so that you can sleep at night and records it. You come and put it in the PC, you get an entire graph of how blood pressure looks like. So you clearly know, is there a white coat hypertension or not? And of course, you can record at home by the patient himself, home blood pressure monitoring. So today the concept is blood pressure has moved out of hospital. But then do we really need to do ambulatory BP for everybody? No, not really, not really. These are research tools. And they're indicated for certain specific purposes, which we will talk about. Okay, you need not learn about ambulatory BP, but keep it in mind how science is progressing. So if you have somebody where you are seeing, for example, this is a normal ambulatory BP recording, how it looks like. Okay, that red that you see is systolic blood pressure. The blue that you see is diastolic blood pressure. And the gray is heart rate. So the standard report comes like this. Each company's report format is different. So you see that daytime BP, that's a nighttime BP. That square box is night. You can see the time, 23:00:13:45, night. So you see blood pressure gradually drops at night. Blood pressure as we go to sleep drops at night. And that is what we call as the nocturnal dip, which is normal, night dip. We are not trying to teach you ambulatory BP. There are a lot of things, an entire, we have a 6-hour session for postgraduate students on ambulatory BP. We are not talking about that at all. Why we are talking about this is because today the concept is, if you look at the office BP, means hospital BP, clinic BP, non-elevated is a definition of BP less than 120/70. So non-elevated. Elevated is 120/70 to 140/90. Hypertension is more than 140/90. So the terms have been changed. Non-elevated. Elevated does not mean disease and hypertension. Right. And not just that. If you look into the arena today, they have opened up into home BP, ambulatory BP at night. And that night blood pressure should be just anything below 120/70. So you see, you could have a person whose blood pressure is high in hospital, but low at night. Opposite, normal at hospital and high at night. So they now, depending on the night BP and the day BP, we have divided people into what is called sustained hypertension. So in the hospital, they are high BP. Home also high BP. There may be a person with white coat hypertension, which means looking at the white coat, their blood pressure has gone up. Clinic high, home normal. That is where there is an indication for doing an ambulatory BP. Masked hypertension, mask. Why mask? Clinic normal, home BP is high. 20% of Indian patients have masked hypertension. And of course, normotension, clinic normal, home also normal. So today, the whole approach to hypertension is different. There's practical implications. See, this is one of our patients who came, very high blood pressure. So like he came, a doctor referred that I think he needs blood pressure medicine. Dr. Tiny Nair undertake the medicine one day, you decide and then start off, right? Look at that. Very high blood pressure in hospital. You can see it goes up to 210, right? But the moment he has gone home, after an hour, every BP is normal. Typical white coat hypertension. So simply because we did an ambulatory BP for him, we said, no medicine, you go home and sleep, right? You don't need a medicine. So these are cases where it is important that you get a ambulatory BP done and rule out. So young man, nothing else is there. Suddenly very high blood pressure. Why? It might be he is a very unusual case of very sensitive white coat hypertension. So keep it in mind. We should not miss them out. And in a specific case, ambulatory BP gives us a lot of evidence. See, we always talk about the night BP now in cardiovascular research. I don't want to impress you about night BP, but then we should understand how the concept is changing. Okay, see, all these years we were looking at, okay, BP, the x-axis is BP, 90, 100, 120, 130, all that. And the y-axis of this graph is 5-year cardiovascular death. Death, right? Very major endpoint. Now let us look at the clinic BP. So he has come to your hospital, you have checked the BP, it is 120/80. So look at that blood pressure, his risk of cardiovascular death, 1.0. Okay, not much. Now this patient one day comes with a very high BP, 170. Where did the risk go up to? 1.2. Little bit high, right? Now, suppose you are looking at his nighttime BP and he had come with a similar nighttime BP of 170. Now look at that. His risk could have been 3 times higher. So the nighttime blood pressure gives us far more data about cardiovascular complication compared to his daytime data. And that's why, as hypertension researchers, we say that if you give me one number of blood pressure for a person to get a decision of how good he is, give me the night BP. But again, I insist, you should understand that not everyone needs a high BP. We'll come to that. Why it is important that, see, there are billions of hypertensive in India. Do you need to do ambulatory BP for everyone? Not really, no. Now look at this concept. This is called masked hypertension. That is daytime ambulatory BP. That green is systole. The orange is diastole. Look at that. That is nighttime BP. Nighttime BP is high. So look at this. This daytime BP normal, nighttime BP high. So when we check in hospital, it will be 140/90. But night BP is going high. How do we find it? Only by ambulatory BP. And you see, when we find it, they have higher target organ damage, more stroke, more heart attacks, more cardiac failure. So we should not miss them out. This is one of the data that we published on ambulatory BP. It's called the India ABPM trial. 27,000 patient data. We were all part of it. This is a very highly appreciated data worldwide, globally, because this is 27,000 patients, very carefully done data. 20% of Indian patients, hypertensives, have masked hypertension. 20%. Who have got night BP high, daytime normal. So the point is, do we really need to do ambulatory BP for all these patients? No. Only thing. So this comes to what is the take home. So important point is, please do not use a very short-acting medicine. Let us say you are using a short-acting medicine, nifedipine. A nifedipine capsule. Blood pressure comes down during daytime, but night it is going up. Instead, if you use a long-acting medication, basically you cover up the night BP. So you need not do an ambulatory BP. Forget about all the night BP, whatever theory we have talked about. Just choose a long-acting medication so that your night blood pressure is also covered up. Now, this is most important to take home. See, understand that. So if you are using an ACE inhibitor, choose perindopril because it's the longest half-life, 17 hours. If you are using a diuretic, use an chlorthalidone or indapamide. If you are using a beta blocker, use bisoprolol or nebivolol. Long half-life. If you are using a calcium channel blocker, use amlodipine. If you're using angiotensin receptor blocker, use telmisartan. Because logically, those are the longest half-life. So please don't choose a short-acting medication. Choose a long-acting medication so that even if you're 20% patients, your mass hypertension will be covered up. You need not spend time doing ambulatory BP for everybody. No. Right. So one take-home point would be use a long-acting medicine. Forget about night BP. The reason why we built up all that is give only a long-acting medication. ACE inhibitor, something like perindopril, diuretic chlorthalidone, indapamide, beta blocker, bisoprolol, nebivolol, calcium antagonist, amlodipine, and ARB, telmisartan. They are hugely long-acting, right? So for mass hypertension, response to long-acting drugs. Now we'll just stop with two short areas which are so very important in India, and one is diabetes. Diabetes and metabolic syndrome. We know, you see, in our time when we were in school, all children were thin and malnourished. Now you look at our own children, right? Everybody is fat and round and globular and no play, and they're all putting on weight. So our entire society is 100 million diabetic, 140 million pre-diabetic. We are turning into a society of metabolic syndromes. And in metabolic syndrome, there is early activation of renin-angiotensin system. And that's why the moment we see a diabetic or a fat person or obesity or a visceral obesity, we try putting them on angiotensin receptor blocker or ACE inhibitor, right? Because they have an activated renin-angiotensin system. Renin-angiotensin system is blocked by ACE inhibitors or ARB, right? ACE or ARB. Now, this is again one of those papers which we did for American College of Cardiology, where we talked about the Indian BMI, how it is different from the American BMI. But this was the important. India has got significant central obesity. And if you're looking into central obesity, look at that. Mechanism of sympathetic activation. This is a very beautiful article where they're connecting obesity with hypertension. It's a complex picture, right? I'm not trying to complicate things, but look at that. If you have obesity on top and hypertension in bottom, in this picture, just look at three important things, because that is what is take home. One, in an obese person, there is a RAS activation. In an obese person, there is sympathetic nervous system activation. And in an obese person, there's a high likelihood of obstructive sleep apnea. So forget about everything. You have an obesity, hypertension coming tomorrow to your clinic. He's obese, he has high blood pressure. Think of, should not I give him an ACE inhibitor or an ARB? Perindopril or telmisartan. Think of, should not I give him a CPAP? Should I do a sleep study and find out, does he have obstructive sleep apnea? And third, don't forget, if you check his heart rate will be high. See, these people don't realize most obese patients, visceral obesity, has a rapid heart rate. Think of beta blocker, right? Most obese patients, though they might sleep off in front of you, they might look docile, they have a faster resting heart rate. So beta blocker, ACE ARB, and a CPAP if there is OSA. So sleep study, ACE ARB, beta blocker. Don't forget about these three components in a person with obesity and hypertension, right? So ARBs and beta blockers for metabolic syndrome. We'll just touch upon dementia because, you know, you might be now looking that a lot of elderly people have dementia. We miss it out because we don't actually check them. If you routinely put them on a mini mental scale, you will find that there's so much of dementia. In fact, when we wrote this article way back in, that was which year? I think, 2019, people laughed at us. We talked about hypertension and dementia in the Indian subcontinent. People said, oh, there's no dementia in India, right? That point of time, people. Now today we know that Thiruvananthapuram, it is 4.86. Look at that. North India, it is even more. Many centers, it is up to about 6.5%. And then East India, it is 10%. Significant number of people today have dementia. And today we know that dementia or vascular dementia has so much relationship with hypertension. But there is a catch, right? For example, this came in New York Times. Study offers hint of hope for stopping dementia in some people. Why some? Why some? So even if you control hypertension, it seems not all people benefit. Now, if you look at the large data, by controlling blood pressure, you reduce dementia, but you reduce a little bit of dementia. And we were not sure why this was happening. Right? It should be, right? We get reduction of heart attacks, strokes, cardiac death. Why not dementia? And then this data came out. This is about 4.5 million people data on dementia and BP. Very, very interesting. Now look at the data. When they look at those people, this is important, between 75 and 80-year-old, 75 to 80, very elderly. And when you look at their blood pressure, you reduce them from 160 to 100. So they are 70 to 80 years, 75 to 80-year-old, reduce blood pressure from 160 to 100, and you see what happens. The dementia goes up. So if you reduce blood pressure in a very elderly person, dementia goes up. In contrast, if you take those between the age of 60 and 64 years, and you reduce blood pressure, you see that dementia actually comes down. Go to the left and dementia comes down. Right. Right, as the BP goes up, dementia goes up. As the BP comes down, dementia comes down. So we actually learned that to control dementia in elderly age, you have to treat hypertension in middle age. And that concept today has very clearly been established. So prevalence of dementia, you can see on the bottom of the age, 50, 75, 100. Prevalence of dementia is increasing over age, right? But risk of hypertension creating dementia decreases with age. And so you see risk of hypotension increases with age. So you need to start treatment here at age 50, not there. So the point is you need to early treat in middle age to prevent old age dementia. Once a person is beyond 75, even if his BP is high, you treat, your dementia will actually increase. Right? So finally, I think we have talked about multiple things like, but I said, what is the take-home message? This last slide would be what we take home after all this looking into so many interesting and mundane things, right? One, your automated BP apparatus shows a little higher systolic blood pressure and a lower diastolic blood pressure. It is unreliable in atrial fibrillation. So when your patient calls up at night telling that, sir, BP is low 40, ask what 40, diastolic 40, you tell that what is the systolic 110, please go to sleep. Right. So automated instruments record a lower diastolic blood pressure. Second, measure carefully. Just somebody is sitting or standing there, just put a cuff and measure and say 120, 80, doesn't matter. Because that is what is important. So you saw all the caveats, right? Sitting on the chair, comfortable, back support, not over dress. Okay, foot firmly on the ground, back straight, resting on a chair, no cigarette, no coffee. They are important. Third, resting heart rate. Your blood pressure apparatus shows the heart rate. Look at that. It's a very important biomarker. Like your troponin or whatever it is, it's a biomarker. It is right in front of you. If you see that your patient's blood pressure is controlled, but heart rate is high. See, heart rate is labile. He may be anxious and heart rate is high. Recheck again after 10 minutes to 15 minutes. If it is persistently high, that itself is a risk factor. Think of giving beta blockers. Third, ACE, ARB or beta blocker in combination depending on what your patient has for diabetic obesity. Because they have multiple drivers including RAS axis and sympathetic. And don't forget the sleep study. You might have an obstructive sleep apnea. Treating sleep apnea might actually give you good relief. Long-acting drugs. Always use long-acting drugs because it is not possible for us to do ambulatory blood pressure recording for the billions of hypertensive, millions of hypertensive that we have in India. If you use a long-acting drug, whether he has masked hypertension or not, it will be controlled. Masked hypertension is night BP is high, day BP is normal. 20% of Indian patients have masked hypertension. You can easily tackle it without even knowing whether it is there or not by giving a long-acting drugs. And we have shown you the long-acting drugs. In ARB, it is telmisartan, ACE inhibitor is perindopril, calcium antagonist, amlodipine, and beta blocker, it is nebivolol, bisoprolol, diuretic, it is chlorthalidone and indapamide. Finally, midlife hypertension drives late life dementia, right? So if you're trying to reduce a stroke or an MI, even in elderly people treat. But if you're trying to prevent dementia above this age 70, 75, by treating hypertension, you're not going to reduce dementia. So we need to be more careful in midlife hypertension. Somebody comes at age 50 and little hypertension, he says, no, I will try salt restriction. Okay, you try. Little later, it doesn't go away. Persistently, it is 150, 100, 150, 100. He says, my ECG is normal, treadmill, echo, everything is normal. But you have to treat this midlife hypertension to prevent late life dementia. So with that, thank you for your time and attention. And I give the podium back to Dr. Prashant. Feel free to discuss, opine, and any questions.
As usual, an amazing session, sir. And you incorporated various trials and images in a very simple format. Hats off to you, sir. Hats off to you. Dear sir, let's start with a few questions. Let's start with one of the most simple question I received. A general practitioner has asked, see, how frequently I should check blood pressure of a non-hypertensive patient consulting me, for various reasons. How frequently? Monthly, tri-monthly, or 6 months?
See, what we say is that, see, the beauty of hypertension detection, unlike diabetes, dyslipidemia, or a scan or complex thing, is that a BP measurement needs a BP apparatus and a person trained to do it, and just about 5 minutes time, right? And it is not costly, inexpensive. Everywhere it can be done. So we today insist that whenever there's a medical encounter, be it a camp, be it your friend who has come, or be it that a child or a man has come with a small injury to the ER or whatever, whenever there's a medical encounter, if possible, please check a blood pressure. That is the standard. So what frequently, whenever you get the patient, please check it, because there is no over frequency of checking. But the point is, at least for a non-hypertensive, at least once a year, people should have a blood pressure checked up, because in this 1 year time, blood pressure might have gone up. So advice would be, as frequently as possible, whenever there is a medical encounter, don't lose the chance. Takes that 2 minutes to check blood pressure. Check it and send. Right? We do it for bystanders. Somebody will say, sorry, okay, sister, BP, okay. Sometimes you might find it is 160, 100. So whenever there is a chance of encounter, do it. And second thing is that if you are just asking about when should I ask a person to come and get a checkup done, at least once a year, if his blood pressure is normal. If his blood pressure is borderline, that means elevated BP, not to the tune of normal, but not to the tune of hypertension, much more frequently. That is at least once in 3 months, to know that is lifestyle controlling it.
Sir, one subset question there. There is a very big habit of checking blood pressure from a medical store or a lab somewhere. There is a lab for going for some test, and they check the blood pressure. It is different from home or office, right? And is it recommendable, or what is your take?
100% recommendable. Whenever there is an encounter with any person.
Sir, no, the measurement is done by a laboratory person or a medical staff.
Perfect. A measurement of blood pressure does not need a doctor. Any person can do it, but guided on that number, what you are going to do has to be decided by a doctor, right? Because we were advising that we can have a small blood pressure kiosk in museum, in beach, Shanghai beach, and where people go to walk. Yeah, fine. But only thing is, depending on that number, you should not jump into a medication or a decision of diagnosis. But then it is always good that you have blood pressure checked up. Lab, park, train station, airport, Sangugam beach, doesn't matter. Wherever you, doctor, nurse, paramedical, non-medical, your wife, husband, anybody checks. But only thing is, suppose somebody checks it is a wrong blood pressure or wrongly put instrument, you should not get carried away by them. Oh my God, 180 by 100, what will happen? I will fall down and die. No. But whenever possible, wherever you have an encounter, unlike if you will say, don't do a cholesterol from a very bad lab because labs may vary. But blood pressure, no. If we are using a standard blood pressure apparatus, which is available in internet, Amazon freely, most we have seen are very accurate. Automated blood pressure, today the chips have become so cheap that they are fairly accurate. Don't use the finger one, don't use the wrist one, use only the elbow.
Thank you, sir. So you made it so clear. So the next question. Many a time, if we are checking BP on, both arms, there will be differences. Which one we have to take?
Higher one. Simple. Because the artery is vary in diameter. Some people might have a little atherosclerosis, or the artery might run deeper, so that the detection of blood pressure may vary. But whenever we check a person both hands and find that there's a higher BP in one hand, we tell them that next time onwards, whenever you check in the arm where there is higher BP. Don't go home thinking that the lower BP is normal. The higher BP is normal.
Okay, sir. Thank you. Now you have already told that in automated BP apparatus, reading the diastolic BP is lower by how many millimeter?
See, normally it is lower. Normally it is few millimeters only. See, as per the theory, as per the data available by the books, it is normally few millimeters, maybe 3 to 5 millimeters. And being diastole, it doesn't really matter. See, whether it is 70 or 65, it doesn't matter. But for all practical purposes, we see when people check at home themselves, many times at night, the diastolic pressure may come down as low as 40. So for people non-medical who are checking at home, our advice is that don't look at the diastolic number at all. Your major cardiovascular disease and everything, your perfusion, your giddiness, your everything is determined by systolic blood pressure. Right. So just think of the systole and let us know the systole. That is for advice for people who are checking it at home. Because other than situations like aortic regurgitation, where you find that BP may be 170 by 30, this lower diastolic pressure does not really matter at all.
Thank you, sir. Thank you very much. It is super. Now, which BP apparatus is best, mercury, aneroid, or digital?
Now everything is digital. See, at one point of time, we used to always say, no, digital is not proper. See, all your car speedometers are now digital, right? We have started having confidence on digital. So today we advise that digital. If your hospital or clinic, you wish to have an aneroid, it is fine. It is fine. See, the aneroid advantage is far less prone to problems because a simple spring meter, it doesn't go wrong. But sometimes you might see that if there's an old automated one, it might be giving you all erratic reports. So, there was a movement all over India that we should have blood pressure apparatus checked regularly at a given point of time in all the hospitals and clinics to make sure that they are accredited and they are as per the guidelines.
Sir, how will you rate that heart for the patient with the pacemaker implanted?
Pacemaker. Very
Ah.
important question. See, pacemaker implant is exactly like an arrhythmia, right? Some pacemaker patients will be totally dependent on the pacemaker. Okay, all our pacemakers that we put now are called pacemakers, which are depending on your heart rate, they work or they stop. So if my heart rate is 60, my pacemaker will give 10 beats and make it 70. If now my heart rate has gone to 80, my pacemaker will quietly sleep. So today's pacemakers are all dependent on your baseline heart rate, and many people vary between normal heart rate and slow heart rate, right? So at a time, if you are totally normal or totally dependent on pacemaker, there is no issue. Whatever instrument you measure, however you measure, BP will be perfect. But if you're in between pacing and otherwise not pacing, the blood pressure is going to change. That is the time when automated BP apparatus, it is not recommended. You physically put a stethoscope and auscultate and find out.
Thank you, sir. What is the ideal time of taking different antihypertensive? It's a very big concern, sir.
See, at one point of time, there was big debate worldwide that, in fact, a large study from Italy, actually, huge study showed that if you take your antihypertensive at bedtime, you reduce your mortality, morbidity, cardiovascular events, stroke, and everything very significantly. High chrono, that like people thought that this study, people are going to get some big Nobel Prize or whatever it is. And then it turned out that the study was totally wrong. It was just cooked up and all that. So the authors had been suspended from European Society and all that. A lot of things happened. But finally, today we know that timing does not matter. I repeat, timing does not matter as long as you are using a long-acting drug. Say, telmisartan acts for 26 hours or 26 hours. Amlodipine 33 hours. Whether you take morning or night doesn't really matter. It will last 24 hours a day. So we say, take it at a convenient time when you will not forget. A lot of patients, in fact, large number of patients say that night when I come home and have dinner, my wife gives me the tablet or wife also takes the tablet, and that is the time I don't forget. Okay, many people say, no, best thing is morning breakfast culture. Hospital or office simplest form. You can choose your time. Couple of simple things is that we don't tend to give diuretics at bedtime. Yes, he has to get up and go to the bathroom, right? So diuretics bedtime, but any other thing you can choose your way you want it to titrate. Bedtime is little more easier for patients to remember and take rather than daytime, but it is choice. Anytime you give, the benefits of antihypertensive remain same, provided you are giving a long-acting medication.
Great, sir. What is the target BP for 75 to 79-year age group with a more stringent control can cause dementia, as you mentioned?
Now it is called, no, see, it doesn't cause dementia. So probably it has been interpreted wrongly. We don't really prevent dementia by treating blood pressure very aggressively at the age of 75 or above. But we certainly have data that we prevent stroke and prevent heart attacks, right? So nobody is saying don't control, but be careful and look into what you are looking at, what you are trying to say. So today we say the concept is the lowest for an elderly person. The 130/80 remains same. But for him, it is the lowest tolerable blood pressure. The term is called lowest tolerable blood pressure. Because there are some elderly people, you bring it down to 130/80, they will say, night when I get up and go to the washroom, I get little giddiness. They should not fall down, right? So the point is lowest tolerable blood pressure without a giddiness, which he is tolerating, would be the best, because a lot of elderly patients are on some prostate medication, alpha-1 blockers, right? They are on alpha-1 blockers, and that also adds up to blood pressure fall. So lowest tolerable blood pressure, but whatever age you take, the blood pressure goal still remains less than 130/80. Understand that frail and elderly people, you should be little more lenient. You should be more soft in bringing down their blood pressure. Okay, elderly person comes to your clinic who has a blood pressure of say 180 or 170/90. Straight away, we will not give 1, 2, 3 drugs together, you eat it. You might get a BP fall. We'll slowly give. These are patients, sometimes we give even one drug. We'll say you take telmisartan 20 and come back after a week, we'll see. Then increase to 40, not control, you add some selnidipine or amlodipine or whatever. So go slow when you get a very elderly patient.
Excellent, sir. Thank you. Sir, elderly patient with a high BP on clonidipine, should we put on other antihypertensives?
Yeah, see, if you are going on a full dose of selnidipine, which is 10 milligrams BID, normally 20 milligrams, 10 milligrams BID, still not controlled, certainly you add some other drugs.
Sir, any role for potassium chloride instead of salt in the management of hypertension?
Yeah, see, potassium supplement has been shown to be beneficial in hypertensives, potassium supplement. Patients who have a tendency for low potassium, it is good. But when you supplement potassium, you should be always careful that you're not producing hyperkalemia, because a lot of these patients have a borderline kidney problem. They might be hypertensive for many years, not detected. They have a little elevated creatinine. So you give too much of potassium, they might develop hyperkalemia, right? So hyperkalemia is a challenge. But those who are potassium deficient, giving a little potassium has been shown in studies to be good for hypertension. But then the point is that one needs to be careful about hyperkalemia. For example, there are some salts. People come and say that potassium salt other than normal salt, can I take the sea salt which contains potassium? They are not effective, right? They almost contain similar amount of sodium, slightly less, but they contain huge amount of potassium. So you might end up with hyperkalemia. Potassium supplement is good. We always say that rather than giving some pot chlor or anything, eat some fruits, right? If you have a tendency for hyperkalemia, take fruits and vegetables which contain so much of potassium.
Sir, in that context, there is a small another subset question where there in elderly hyponatremia is a concern. in many situations. And the doctor is advising, added salt. And in the midst of a hypertensive patient, is it recommendable? To what extent?
See, in an elderly hypertensive, always this problem of hyponatremia can come in. So we need to be careful. One, elderly people, we should be careful before we give a larger dose of diuretic. So that is what commonly produces hyponatremia. So they might be, see, many times we don't realize. You ask them, he might be taking, I am taking telmisartan, what? Telma H or Telma CT or, something. Chlorthalidone, hydrochlorothiazide. So the moment you are taking this, that is your reason for hyponatremia. So some of these diuretics are piggybacked on a medicine which can be hidden and we may not look into the prescription. So chlorthalidone or hydrochlorothiazide added to a standard medication can cause hyponatremia. Some elderly patients can also get hyponatremia, and even in the absence of diuretic, there probably you should correct the hyponatremia as we standard do.
Thank you, sir. What is the importance of pulse pressure and the importance of narrow or wide range?
Yeah. See, pulse pressure basically tells us about the stiffness of the artery. See, as we grow older and older, the systolic pressure tends to go up. And the diastolic pressure tends to remain same or slightly come down. So what happens? The gap increases. So as we grow older, the pulse pressure tends to come up. That's normal. So a very significant increase in pulse pressure might denote a stiffness of artery where the systolic pressure is high and the diastolic pressure is low. Right. There are diseases where the pulse pressure may be extremely large. For example, aortic regurgitation, right, where systole may be 170, diastole may be 30. So whenever there's a huge pulse pressure, you'd always say have a full cardiovascular checkup done and see, is this an isolated systolic hypertension or is this a reason valve disease or something which is causing your diastolic pressure to come down. Any vasodilatation would produce a lower diastolic blood pressure and increase the pulse pressure, of course.
Sir, why did you recommend bisoprolol and nebbisilol among the beta blockers? Is it because they don't raise lipid levels?
Yeah, multiple. That is certainly, we didn't mention that, but it's a good point. See, when we take a beta blocker, the challenges are one, beta selectivity, because beta blockers can cause bronchospasm and worsening of asthma. Beta blockers can cause erectile dysfunction. Beta blockers can cause claudication, right, in a patient who has got a peripheral vascular disease. So if we choose a highly selective beta blocker like bisoprolol and nebivolol, which are highly selective beta blockers, we know that they don't or very minimal effect on claudication distance, erectile dysfunction, or bronchospasm, number one. Second, all these new highly selective beta blockers are metabolic neutral, which means they don't worsen HbA1c, they don't reduce HDL, they don't increase triglyceride. So they are lipid neutral, they are sugar neutral, and they don't give rise to all those problems of bronchospasm, erectile dysfunction, and peripheral vascular disease. So that is why we tend to choose. The reason I showed here was a long half-life. That also, of course, is there.
Sir, then the another doubt is, when medicines like amlodipine is given, there is pedal edema. When not always, then the pedal edema develops. Two questions there. One is, do we need to change the drug if the patient is accepting that pedal edema? Second, if we change, what is the best next option?
Two things are there here. We should understand that hypertension is an asymptomatic disease. Okay, let us say heart failure. Heart failure patient will always have pedal edema, right? We give them so many drugs, but they come and say, sir, thank you for treating me. Now my dyspnea has gone. Because he is not even bothered about minor things. He has a major disease. He says, I was unable to walk till about a month back, sir. After your treatment, I am walking. But a hypertension patient has no symptoms. So the moment they develop any symptom, whether it is bronchospasm because of your beta blocker, whether it is calcium antagonist induced pedal edema, whether it is hyponatremia because of your diuretic, or whether it's a cough because of your ACE inhibitor, he will not accept it. He will say, Oru prashna mandaila, Dr. Tiny poi kandu, oru tablet BP nu parnyon chedu, da kandili po kailu ni. Right. So in asymptomatic patient is very unlikely to accept things like pedal edema. And pedal edema, despite it is harmless, it's a problem. We can't put his shoes on, he sits with his socks for a long time in a flight or in train, he might get swelling there, he might get itch and get an injury there. So I think if there is a significant pupil edema, we should all strive to change it. Now there are two ways. One, either you can change this calcium antagonist to some other newer calcium antagonist, cilnidipine and acilindipine. There are two new calcium antagonists which have much lesser pupil edema than amlodipine. So change to cilnidipine or change to acilindipine so that your pupil edema comes down. Or what you can do is you totally change calcium antagonist and give something else. You have ACE inhibitor, you have ARB, you have got diuretic, you have got beta blocker, change something else so that the pupil edema goes away. It is better not to just leave it unless it's very mild. Tell him to do some exercise, it will go away. If it is significant, it is always better to take into consideration because tomorrow he might see another doctor, him who might say, you have got pupil edema. So it is better to always change it either to newer calcium antagonist or some other medication.
Sir, drug of choice for isolated diet.
Yeah, one thing is what you said. Please don't use a diuretic if your patient has developed pupil edema because of calcium antagonism. The edema will not go and he will also develop hypovolemia or hypotension, hyponatremia.
True, sir. Thank you, sir. Sir, drug of choice for isolated diastolic hypertension with dyslipidemia and hypothyroidism. Say BP 130/90 with heart rate 70/80.
Isolated diastolic hypertension actually is pretty uncommon and had been. Systolic is we know. Isolated systolic hypertension always choose a calcium antagonist or a small dose of diuretic. Isolated diastolic, the data is not very clear, but most of them are driven either by a aggravated RAS axis or a sympathetic axis. Easy to find out. If he has got a rapid heart rate and you are finding all features of sympathetic overdrive like tremor, he has got anxious and all that, go for a beta blocker. If not, go for a RAS inhibitor like an ARB. This is the for hypothyroid, treat first the hypothyroid. Because on treating hypothyroid, many often you might find that his blood pressure might become normal, like your sleep apnea or treatment with a CPAP, his blood pressure might become normal.
Sir, now there is a very frank question, like, the first line drugs to start in systemic hypertension. It should be systemic.
Yeah, first line drugs, today it is pretty standard. We use a RAS inhibitor with a calcium antagonist or RAS inhibitor with a diuretic. Now in India, most people tend to prefer a RAS inhibitor with a calcium antagonist, which is available as a single pill. You have combined telmisartan plus amlodipine, telmisartan plus cilnidipine, or amlodipine with whatever it is. You can get a combination, one single tablet. That is generally the starting point. Not getting control, you can always add the other drug like diuretic. So you have a RAS inhibitor, you have calcium antagonist, you have got diuretic. So take your pick and choose. That is the first line. Now, if you are clearly seeing something else, whereby you are choosing something, you choose. For example, you find young man, sympathetic driven, highly anxious, tachycardia, tremor. He says, sir, I don't know, I don't have hypertension, sir, will you treat me? That person will bless you with your life if you give a beta blocker, right? So the algorithm and the guidelines are all to help us, but it is your individual choice. A person who was highly sympathetic driven, start on a beta blocker. He will do good.
Sir, Jayaprasad sir, our Amardeep Bhavke, Jayaprasad sir has made a comment. Nocturnal hypotension is a non-risk factor for progression of glaucoma and non-arthritic ischemic optic neuropathy. So can we avoid night dose or modify?
See, all these new drugs, including long-acting ARBs, long-acting CCBs, long-acting diuretics, all of them have a very smooth blood pressure lowering effect. They don't produce a sudden drop of blood pressure. So for them, as long as you are giving them in the indicated dosage, whether you take at night or morning has not clearly shown to increase glaucoma or increase NaION. Okay, so you can give it at bedtime confidently. In a particular patient, if you see by ambulatory BP that right after giving that medication 2 hours later, he has a significant drop and this patient has an NaION or a retinal issue, please go ahead and change it. Nobody says no. But generally, for most of the hypertensive patients that we see, it doesn't really make a difference. If you have a patient who certainly you are finding that he might have an hypertension, go ahead and give it in the morning.
Yes, sir. How to manage blood pressure in a pregnant woman with hyperemesis and persistent low BP and giddiness? Blood pressure. He has a certain blood pressure.
This is a different thing altogether. Hyperemesis is not my area of management.
Yes,
But
yes,
then I think you should standard management of hypotension, IV fluids and all that.
it's a different
Hypertension in pregnancy is a very, very challenging
important
area. Where I always advise that if you have a hypertensive lady who is pregnant, please refer to a specialist who clearly knows about the drugs and how to treat, because it's a very, very touchy area, not just pharmacologically, clinically, but also legally, right? Legally. Because we see so many young ladies prescribed on, for example, telmisartan. We on an average, I see once a month, young lady prescribed telmisartan, regularly taking telmisartan, now has become pregnant. See, that's the worst thing that can happen, right? In pregnancy, we should never give an ACE or an ARB, because the fetal kidney may be damaged, malformed. So if it's a lady who is likely to get pregnant in that age range, please do not give an ACE inhibitor or an ARB. Choose anything else. You give calcium antagonist, give beta blockers, give diuretic, doesn't matter. But then please don't give an ACE or an ARB. So that might end up in a legal problem. Unfortunately, if the baby has a problem, the patient might take you to the court telling that why the doctor didn't tell me that there's absolute contraindication. So ACE and ARB are absolute contraindication in pregnancy, absolute. So by the time she misses one period and knows that she's pregnant, she might have been taking for the 20-25 days, she might be taking the tablet.
Sir, what to do if only the diastolic value is high?
See, that's isolated diastolic hypertension had been subjected to very many articles. The largest data shows that probably it doesn't carry much of a risk like the combined hypertension or the systolic hypertension. But nevertheless, if the diastolic blood pressure is high, the ideal treatment is clear. If you have a sympathetic overdrive, treat with a beta blocker. If the tachycardia is not there, not sympathetic overdrive, which is most patients, treat with a RAS inhibitor. So ACE or an ARB.
Sir, old teaching of age plus 100 is normal systolic pressure. Is it still valid?
No.
Okay, sir. Now, sir, you have mentioned that there is no cardiovascular symptom in hypertension. Then why patient shows dizziness and we go for IV normal saline infusion?
The IV normal saline infusion is hypotension, right? I was talking about hypertension.
Sir, now, how can a patient with a variable BP at different times of day can be managed? Any role of spacing of medicine?
Yeah, you can see today's medicines are all long acting. So by spacing medicine, you don't really gain much, but in an individual patient, you can always space so that, he doesn't get hypotension. Probably a patient who is getting hypotension with medication may not need that much of dose, right? He might actually be needing much smaller doses.
Sir, then can you mention your comments about salt intake in a hypertensive patient?
Yeah. See, we say simple, reduce salt by half, right? Things which contain a lot of salt, don't use additional salt in the table, and ask the wife to use half salt of what she was using for cooking. Avoid pickles, papadam, achar and stuff like that, which contains very high amount of salt. So, which means you kind of reduce about 25 to 30% of salt. This is very important because in India, normally we use far more salt than recommended by WHO. So it is about, we use double that of recommended. So we use about 10 grams of salt rather than 5 grams what is recommended. So I think we should try to cut down, even for healthy people, right? It is not good that take a lot of salt. Especially children today are eating all those junk food and all that, McDonald's and all that. They're highly salted food. All these processed food are highly salted.
Actually, when we take health awareness session, we say that you should place your salt in your locker and make sure that you take 5 grams per person in your family. And that is the total 24-hour usage limit. Okay. Sir, is there any relation with the its time is a bit going on. I'm so sorry, sir. There are a few more questions. Is there any relation with the bradycardia or arrhythmia in patients taking long time ARBs?
No. ARBs don't give rise to arrhythmias. ARBs are pretty safe. ARBs are one of the most prescribed medications nowadays. They don't really give rise to arrhythmias. No.
Sir, any comment on hypertension control in early stage of stroke?
Oh yeah, see, that is a very specialized thing. So where, a team of people comprising of cardiologists and neurologists take care of stroke. Because, the whole basic idea is that stroke is where the perfusion of the brain is reduced. And to compensate, the body pushes up blood pressure. So say about 10 years back, we were all running with nitroglycerin and nitroprusside and vasodilators, give IV and bring down the blood pressure. Today, we know that is wrong. We actually don't want to bring down the blood pressure unless it is something like more than 210 or 110 diastolic, unless we are thrombolizing the patient. So they are a very, very niche area. So that itself is a class which we take for how to control blood pressure in stroke, both the hemorrhagic stroke and thromboembolic stroke. So that's a huge topic by itself, but it's a very, very challenging area where you should be very careful in lowering blood pressure. Lower blood pressure, the stroke area, the penumbra might increase and patient might end up with a larger stroke.
Sir, now if heart rate goes below 40 in patients on beta blockers, do you have any comment?
Yeah, and reduce the dosage. See, normally we say heart rate, only if you bring down the heart rate between 60 and 55, then your patient is well beta blocked. So if your patient comes and says that pulse pulse oximeter heart rate was 55 or even 50, then it matter. 40 is too low. If a patient really develops 40, I might actually cut down on beta blocker dose, especially we are talking about hypertension. See, the patient who has got heart failure is different. You want them to be totally beta blocked because he might have had a arrhythmia, VT, whatever it is. So that's different. But when we are talking about hypertension, if the heart rate is 40, please try to cut down on the beta blocker dose so that heart rate goes up a little bit.
Sir, the management of hypertensive urgency, any few words, sir, in a,
it's a very, very, very niche area where, hypertensive. See, here I would like to say only one thing. Very often we get a call from the ER or junior doctors telling that, sir, the patient 180 by 100. And the sir, nitroglycerin in the patient symptom. That is not an hypertensive emergency. At best, you can call it an hypertensive urgency, right? See, emergency, urgency, difference. If you have an emergency, you have to have an ongoing new target organ damage. So very high blood pressure, somebody is developing a stroke, somebody is developing a cerebral hemorrhage, somebody has a dissection of aorta, somebody has an acute coronary syndrome, MI, somebody has severe chest pain, somebody has pulmonary edema, somebody has cerebral edema. They are all acute emergencies where we should admit the patient and control BP. But when a patient comes, 180, 100, does he need medicine? Yes. But that is not an indication for admission. Nothing will happen. Start them on tablet, maybe calcium antagonists, telmisartan, whatever you choose. Start and send them home, ask them to come after 3 days. Provided you are sure he has no cerebral problem, he is fine. That's a patient low pile. Doctor 190 by 100. That is not hypertensive emergency. Right? He has very high BP, but it is not an emergency. Emergency is when there's an ongoing new target organ damage. Mute, Dr. mute. You are mute.
Sir, just to clarify, a patient presenting with hypertension, he already on antihypertensive, and the patient has a documented hyponatremia, is salt intake recommended? Enhanced salt intake for some time.
Find out what is the reason for hyponatremia. Most often you will find there is some other medication causing hyponatremia, or there might have been some fever, or there might be an SIADH, or there may be some other medical reason for hyponatremia. That go accordingly. So that if needed, you want to give salt supplement, yes. Whatever you manage that and then go back to. Please avoid drugs like diuretic, which can cause hyponatremia.
Sir, when you said diuretic, one thing is that very many elderly people keep large amount of tea or coffee in their flask and they drink a lot and precipitate hyponatremia, right, sir?
Correct.
Right, sir. Sir, thank you very much, sir. But John Panikkar, sir, is about to sleep, I think. And that reminds me about sleep and hypertension, even though he has not asked. Please share a word. Last comment.
Actually, I want to congratulate Dr. Tiny for a wonderful talk. Very, very, very informative and very much practical also for the practicing physician. It's very useful. And just I want to say, as he said, I am happy that he has mentioned the obstructive sleep apnea. But even insomnia can also, there will be of course, there is sympathetic overactivity part of it. Then I want to just ask Dr. Tiny, see, there are certain people who are working outside, manual laborers, and is it possible to insist that they should have a salt restriction, because they will be setting a lot, particularly in a tropical country like Kerala? Is it?
I really don't know. Depending on their diet, perhaps I don't know how to tackle that problem of those who are working outside, and their diet pattern might be different, and what should be advised. I think basically we should probably advise them that as long as you something which is very salty, try to avoid it, whether you are taking keto. Yes.
Yes,
And
yes,
like you
yes.
sir said, it is very important that, like Dr. Prashant also said, sleep is very, very important. Today, one of the cardiac risk factor is sleep. Exactly like cholesterol, hypertension, everything. Sleep is a very important factor. So
there should be some relationship between the nighttime hypertension as well as sleep pattern.
Yes,
especially if they are not going for all the deep sleep, particularly. So that should be one of the that's a correlated. We can correlate between these two also there.
Because now we are doing so much of ambulatory BP. We have so much of now ambulatory BP that being done, and we have an entire class for postgraduate students on ambulatory BP. So we know how your obstructive sleep apnea looks like, how a non-dipper looks like, a hyper dipper looks like, all different. No, you saw that nighttime BP itself has so much of determinants, CKD,
absolutely
intensive. Yes, sir.
Sir,
absolutely.
There are no words to thank you, sir. It was an excellent, simply great session, and I think this session should have reduced the hypertension or the blood pressure of many general practitioners, because handling a hypertensive patient in a clinic, you have made it so simple, so it's very clear. You have brought clarity to the practice, and thanks a lot, sir. Thank you very much. Friends, let us join our hands together, to give a loud round of applause to our beloved Dr. Tiny Nair, sir. He's always, he's very simple, as I told you. He's very approachable, and always make sure that let us learn from the right people at the right time. And the food in front of a starving person will not satisfy his hunger. He must put forth his hand and eat. Listening is not enough. Living these principles are very important. That's what I meant to say through that statement. Friends, next very important topic is mastering dyslipidemia. Yet another stalwart, Dr. George Goshi is going to come next Thursday, sharp at 8 p.m. Please join us with your friends across the globe. See you all. Have a great night. Live simple. Stay happy. Like IMA PP scheme, PPS, always be pleasant, always be positive, and keep smiling. Thank you. Thank you all. Good night.
Right, good time.